I'm really very pleased to join with you. I hope everybody, I'll speak as clearly as I can. If there are any difficulties with understanding, don't hesitate to stop me. I'm happy to introduce you to the McGill Center for Translational Research in Cancer. And it requires a definition of translational research. We generally think of this as a bench to bedside, but it's much more actually it's a much more complicated trajectory. What is translational research and why it is important? And today's translational research oncology is really a trajectory. So on the one hand, people working in the laboratory studying mechanisms, say of drugs or of genes or of molecules, are on one end of the spectrum. And sometimes people who create preclinical models, transgenic mice, etc., consider themselves translational researchers. And this is an interface of translational research. But then we're now also looking at molecular profiles of human tumors in large repositories and archives, and translating that into clinical translational research is another interface. So in fact, you have people calling themselves translational scientists who span all of this, and all of them are correct. They're all participating in translational research. The mission of our center is to translate laboratory discoveries into applications that at least can be tested to result in impacts for patients. And we have a variety of research themes shown on this slide here, and I'll show you some examples of the research, but each of them, from radiation therapy to molecular pharmacology, are things that all of us are developing, but now we're developing digital AI-associated radiomics, for example, and molecular modeling of mutations, and then in silico screening of new drugs. And these are the kinds of things that are developing here very rapidly to bring new therapeutics and new approaches to therapy to the clinic. And to do that, you have to have a variety of, I'm not sure if you see my marker, I guess not, but to the right on top, we need a lot of core facilities, a clinical research unit that is expert at doing early phase 1, first-in-man studies, a cell processing facility like a white room, so that we can do those kinds of studies. We need a research pathology core that really focuses on the needs of the researchers, et cetera. So, and in addition to that, we need a variety of partners, and I'll describe some of these partners here, but these are all consortia that exist in Canada and globally. The WIN consortium, you may be familiar with, is based in Paris, and it includes 35 cancer centers across 4 different continents. So the Translational Research Center at McGill has an integrated view of complex clinical and research questions. It requires strong clinician scientist faculty, excellent MD PhD collaboration. So some people are both clinicians and scientists like myself, but sometimes we have MDs, doctors that are only in the clinic, and PhD scientists only in the laboratory, and we need to be able to create those interactions as strongly as possible. And at the same time, best clinical care is what we strive for. And that really means precision medicine, and I'll talk about that a little bit more. But moving into a next generation of knowledge, using multidimensional profiling of tumors in the context of therapeutic trials, not just looking at the genome, at DNA, and I'll describe that in a few minutes. There always should be a strong fundamental research input, both upstream in developing a clinical trial, and then as a result of, say, biopsies and material that's obtained from the patient tumor samples in the context of the trial, you can generate new biological information. And then, of course, the host, the patient, has to be profiled germline mutations, and of course the immune system at baseline is extremely important to understand. So this requires new models of care beyond the boundaries of a clinic just for breast cancer or just for the elderly or the young. They may be molecular profile specific tumors. For example, we used to have a Herceptin clinic. It was convenient for the pharmacists to have all the patients with amplified HER, most of whom were breast cancer patients, come at the same time, and the pharmacist would prepare trastuzumab for them. But it turns out that once we started to see that a small group of gastric cancer patients were also benefiting from this, it wasn't a bunch of women with breast cancer. In fact, this was a signature-based clinic. Now, our organizational structure here, I lead this, but we have some very strong scientists that have divided the work among themselves. Wilson Miller is the director of the clinical research unit that does the earliest phase clinical trials, first in man studies. Peter Cavan directs the clinical research program. These are later stage trials of drugs that are likely to be approved. And so they're studied in the clinical setting, closer to, so the nurses actually are getting to see and use and have experience with drugs that are soon going to be approved. So phase 3 kinds of studies are done in our usual clinic. And Josie Orsini-Siegel is the director of the molecular oncology group that tries to generate fundamental understanding in the context of clinical trials. And I'll go through some of the things that that group has done. It really spans a whole spectrum of fundamental science. Here, dysregulated gene expression in cancer and mRNA signaling, two very, very strong and young scientists. We have people working on genetics and genomics of cancer. Will Fulks actually described an entirely new cancer syndrome, small cell carcinoma of the ovary, with hypercalcemia by tracking down this particular mutation in the germline of a small cohort of patients. And Claudia Kleinman has been an expert in merging expression and epigenetic data, particularly in pediatric gliomas. We have some strong expertise in metabolomics. Michael Pollack is really world-renowned for his work, and so there's fundamental and clinical work going on here, as well as, again, work on the immune system and the identification of specific immune-related new targets in breast cancer. We're very much like many groups in the world working on aspects of DNA repair, genomic instability, and cancer. And these are just two recent examples of high impact publications by two of our experts focusing on DNA repair as a mechanism of resistance to therapy. Now, novel drug resistance and novel therapeutics is a particular focus of ours. I'll start with the one at the bottom. And this is a young investigator who's identified a new target in patients with KIT mutated related melanoma. The paper published in Nature Medicine at the top is part of the WIN consortium, and I'll discuss that in a minute, where we did a study on 4 different continents. We were the only ones in Canada, and in fact, in North America, because while Health Canada approved it, the FDA was a little bit slower. And we expanded from just doing genome-based profile to look at the transcript, to look at the expression of mutations in order to guide therapy. In other words, we do biopsies of tumors and look for specific mutations that might be actionable. There might be an activation of a gene, and we have a drug that inhibits it. Now in this study, we discovered that if you look at the RNA, it doesn't always correspond to the mutation. You may have an amplification of a gene when you look at the RNA level. there is no increased expression. So it tells us that we have to start looking beyond the genome. This study was done in France, in the USA, although, as I say, they came very late, in Spain, in Val d'Hebron, in Israel, at Sheba in Tel Aviv, and here in Canada at the McGill Center for Translational Research in Canada, in cancer. And basically, this trial took biopsies of the tumors and did a variety of profiling and used both RNA and DNA in order to find a match, a specific drug treatment. And in fact, it was a positive study. It showed that if you use both transcriptomics and DNA, you could actually match more patients to specific drugs and have an impact on their survival. Now, at the center here, we're also very focused on sequential studies of biopsy-based trials. So, for example, we have a series of trials. These are in lymphoma, in triple-negative breast cancer, in colorectal cancer. This is the colorectal cancer schema, where patients with metastatic disease have a biopsy before they start standard therapy. And some of them, more than half of them, respond to first-line chemotherapy, but all of them relapse, at which point we do another biopsy. And that second biopsy, compared to the first, is actually, there's a paper just being submitted now where we identify new targets that probably are responsible in part for the generation of resistance. But this then becomes the opening biopsy, and we look for targets in this biopsy in order to line up a second-line treatment. And so we're doing sequential biopsies with analysis, and that helps us identify this patient. The problem with all of the new drug therapies is that we're treating metastatic disease, but yet if we do the profiling based on the primary tumor that's in our archives, the tumor is very, very different and has evolved. So we want to have a picture of the tumor that we're treating in order to really understand why we're responding or not, patients are not responding. The promise of precision medicine is that by optimizing patient matching a specific mutation to a specific treatment, we could avoid predictably ineffective, toxic, and costly treatments that we know are not going to be working, and improve overall clinical conditions. And we're starting to see, for example, in the case of crizotinib that you must all know about, these are in 3 or 4% of non-small cell lung cancer. There's a translocation abnormality of the ALK gene. It has a variety of different partners, but the most common is EML4 ALK. And if you select only patients with non-small cell lung cancer who have this translocation, 97% of them respond. This is a waterfall plot. Everything below the x-axis is a response, and only one patient was resistant and grew. So all the patients responded, and so this drug was approved by the FDA with just a couple of hundred patients. And I think that's a general theme here at the center and in general in drug development. So the idea is that you identify a patient that by virtue of molecular profiling that has a driver mutation, and if you select the right patient and match them to the right drug, they should all respond, like in the crizotinib on slide 15. Now, this would have been a beautiful picture, except it doesn't turn out to be true. I'm showing you slide 16 now. Are you on the correct slide? It says challenge, PI3CA mutation. And here the patients are all breast cancer patients, and they're selected, highly selected, again, for a mutation that activates the PI3 kinase pathway. And they're given a drug that inhibits that pathway. And if it's anything like crizotinib, we would have thought that a lot of these patients would respond. But in fact, there are only a couple of patients that had a partial response. So the thesis of taking patients with specific activating mutations, selecting them for an inhibitor of that driving pro-growth pathway would necessarily give you high response rates is starting to break down as we look beyond some of the first, what we call low-hanging fruit. So in general, personalized oncology is based on DNA sequencing. These are the studies. I'm sure you're seeing Foundation Medicine kind of profiling platforms. And they just look at the DNA, but the genomics really is just the tip of the iceberg, because as we showed in the Winter trial, if you add transcriptomics, you get some better matches. And we believe that you actually have to look at proteomics and even epigenetic changes, whether a protein is phosphorylated, for example, or activated, may be important as well. So it's possible that even though there's an activating mutation in the pathway here, that actually the proteins, which are the target of the drug, are not really activated. So next slide, slide 18, the limitations of precision medicine based on genome only. There are discordances between the genome and the proteome. We know that now. RNA transcript abundance does not predict protein, and protein really is the target of the therapy. That's what the drug usually inhibits. So if the DNA and even the RNA do not predict protein, and of course not phosphorylation of protein, then you have a problem. You may have some patients that are mutated, but the protein isn't made. So they look like they're false positives, but there may be patients where there's no mutation, but there's epigenetic activation of the protein. The protein is there a lot, and you haven't even offered them the treatment because you're screening them by mutation. This is just data that shows you that both of these slides, 19 and 20, I'll just group them together just to show you data that the RNA transcript abundance doesn't predict the protein abundance. Copy number variation showed strong effects on mRNA abundance, but few on the extent of the protein. So you can have an amplified HER2, for example, in the DNA. It may or may not show up in the RNA, but it doesn't consistently show up in the protein. So that giving, say, an anti-HER2 drug, even if you just know the DNA amplification, is not entirely predictive. And this is on the bottom right are drug sensitivities versus mRNA, and you see that there is not a very good correlation between mRNA and drug sensitivity. So we have a champion here at the Translational Research Center. His name is Christoph Borchers, who is a proteomics expert, and he uses a variety of mass spec-based technologies in order to actually measure the proteins. So we are currently studying the samples of patients given PI3 kinase inhibitor based on mutations, and then looking at their proteins and seeing whether or not their response correlates better to the proteins than to the RNA. Now, I just want to mention that there's a whole suite of tools in personalized medicine now that we're developing as well here. And this is a patient with gastric cancer that was HER2 positive. And we were able to take a piece of the tumor and develop a patient-derived xenograft. It's growing in mice. It looks very much the same, and the HER2 is amplified slightly even more in the mouse, and the patient responded dramatically to Herceptin and a small amount of chemotherapy for about a year, and then tumors started to grow, and so sure enough, we saw a clone of his tumor that was resistant to trastuzumab. This is now in the mice. And so we were able to do clinical trials in the mice of new drugs. And sure enough, the drug TDM1, which uses HER2 as a target to deliver a toxin, is very effective even against this resistant clone. So we went back to the patient and treated the patient with TDM1, and you see quite a dramatic response here for at least 6 or 8 months, and then the patient started to relapse. This is metastatic, lung metastatic disease from gastric cancer on a CT scan. And then, as you all know, we're starting to shy away from biopsying tumors, but looking in the blood. And so we developed a blood-based cell-free DNA assay for HER2. You see, this is the CEA that we were following him with, and it kind of went up and down in relationship to the disease. But in fact, if you look at the blue here, it really preceded CEA. The HER2 went down very rapidly with starting TDM and stayed down until a relapse at the end. So we're developing cell-free DNA in blood so that we can follow disease as well. Are you still with me? You hear me? Okay, good. So I just a few more slides.
Sorry,
I know
I'm sorry to interrupt you, but you are on the slide precision medicine, right?
Yes.
Can you tell us next so we follow perfectly? Okay, thank you.
Yes. Okay. Next. Personalize my treatment. This is a large Canada-wide trial that we're doing. It's not a trial; it's a registry, because we're interested in seeing patients before they relapse and before they need treatment, and it's done by Exactis Innovation. This is a Canadian Center of Excellence in Precision Medicine. The Canadian government is funding this, and we started this in 2014. And the idea here, next slide, it's called Personalize My Treatment. Slide 25, is that we're building a registry of patients who have cancer that is either resected or is in remission. So patients that are at high risk of relapsing. And we ask the patients for 3 things. We ask them for permission to follow them longitudinally and prospectively. We ask them for permission to access their tissues so that we do molecular profiling. And we ask them, this is most important, for the right to recontact them if we find a match. If they relapse and there's a clinical trial that they can match to. So far we have 44,500 patients in this registry. And this is a way of drawing pharma to us because they're interested in looking at for patients that have specific and sometimes very uncommon molecular profiles. So we think that clinical trials are turning out to be something we can all do, but the challenge now is turning to finding the right patients with the right mutations. So Personalize My Treatment is a way of building a registry of patients, profiling them, and then making them, being able to recontact them when a clinical trial that fits their profile is available. Next slide. We also in the center have a very active radiation oncology program led by Tae Wong, who has become an international expert, particularly in brachytherapy of the GI tract. And I won't go much further into that. Next slide. I referred to our artificial intelligence assisted radiomics program for diagnosis, which is a relatively new access. We're using machine learning to analyze imaging. And Reza Farghani is formerly trained as a radiologist, but he's redefining surgical margins by looking at head and neck tissues and images. And we think that this is going to help both in radiation therapy and surgery and even in diagnosis and following diseases to use AI in imaging studies. I think we're all seeing worldwide that AI is steadier than some of our best radiologists, less prone to error. AI machine doesn't get tired. It may the plug might get pulled, but aside from that, it may actually be a very useful tool for all of us. And then I just want to finish by telling you that we consider the entire spectrum of aspects of cancer patients to be an important focus for research, including psychosocial oncology research. We have a very active program here as well. So the Translational Research Program covers all of these aspects, and you see here outcome research, psychosocial research in young adults with cancer, anxiety-related and depression-related studies. And now we're particularly interested in patient-related outcomes and using digital health to provoke updates and patient-related outcomes from patients between visits. We've seen recent studies in the past few years that show that if you simply ask the patient to wait to the next visit, you're missing an opportunity to intervene. And when these interventions are made, they can have significant impact on survival. Next and final slide, the conclusion: cancer research has entered a most exciting and promising period. Molecular medicine means redefining cancer as being composed of multiple subgroups of patients, each with its own defining molecular signature. Each of these subgroups has its own disease trajectory, and each one of them ultimately will have their optimal therapy, and that's what we're in the process of defining. This requires a strong multidisciplinary team, and that's one of the things that our center has really focused on, bringing different disciplines together to focus on a problem, to examine and profile cancers and patients at a multidimensional level. So we have a very active immunotherapy protocol, but as we're all experiencing, the toxicities of unleashing the immune system can be quite dangerous. And so we're profiling both the patients and trying to understand who gets what, if we can predict who's going to get the most serious side effects. This is true for the tumor as well as for the patients, for example, as I said, who require immune profiling, as well as understanding their individual psychosocial status and needs. So we profile the tumor, we profile the patient's psyche, we profile the patient's immune system in an attempt to come as close as we can to personalizing therapy. And with that, I'll conclude, and I'm really happy to take any questions.